It's always a challenge to be the fourth speaker speaking of the same subject, and it's a choice between saying the same things than the three others, or saying the opposite, which may be more interesting but less friendly. So I'll try to find my place between the two. And speaking of chemotherapy, of course, means finding the place according to surgery. So the first thing is, what are the treatment options for synchronous, initially unresectable metastasis? Of course, have you heard the first treatment is controversial. Chemotherapy, which is my subject now, it's wish timing, before or after. What about surgery of the primary tumor? We just had this talk. And surgery of the metastasis, of course, if they become resectable. And this is the interest of... I'm sorry, I tried to put the chronometer, but it doesn't work. So upfront primary tumor resection, we just had a talk on that. The rationale is to avoid the complication related to the primary tumor in place, and particularly if the chemo includes bevacizumab, and in the United States, most of the patients had resection of the primary tumor. Now, the question which has already been raised, can the primary tumor resection improve survival? The survival benefit has been suggested by retrospective studies, but I must say that these studies are potentially biased because, of course, the patients who received resection were probably the patients having more limited metastatic disease. So the only answer is prospective studies, and these are very difficult to organize, and I hope there will not be too many competing studies in Europe, because if this is the case, they will all fail. Upfront primary tumor resection, the complication rates are up to 11% major and 20% major. Of course, when they occur, they delay the administration of chemotherapy. Now we have very efficient chemotherapy regimens, and we know that the chemotherapy is not only active on the liver, but also on the primary tumor. What about the rates of primary tumor-related complications if the treatment starts with chemotherapy? We know that it's quite low with this study which has already been referred. There's also this NSABP C10 phase 2 prospective study in which the investigators looked at what happened to the primary tumor if the patients with synchronous mets received primary chemotherapy with FOLFOX and bevacizumab. And the conclusions, to make it short, were that avoiding resection of the asymptomatic resection primary tumor did not result in an acceptable rate of primary tumor-related complications and did not compromise survival. One of the objectives of chemotherapy is also to convert some of these patients with unresectable mets to resection. Either that can be done by intensifying chemotherapy or by adding biologics. So what regimens can be used? You have seen this diagram published by Gunnar Folprecht. The better the response, the higher the chances for resection. So looking rapidly at what are the agents and the drugs that can be used, of course, cetuximab, you know these studies, a combination of cetuximab with FOLFIRI or with FOLFOX. In these studies, now we are looking at response rate, and in all these studies, the combination of cetuximab has increased the response rate of chemotherapy only. These Chinese studies in unresectable liver metastasis compared FOLFOX or FOLFIRI with or without cetuximab, and the rate of R0 resection was higher in patients who received cetuximab, and this was a prospective study published recently. Panitumumab, we have approximately the same information with the PRIME study, and again, we are looking at response rates which is increased. Now, this study has been reviewed, and also in the patients, the group of arm with panitumumab, the complete resection rate was higher than with the FOLFOX only. Now, what about bevacizumab? You know these studies. We are looking again to make the metastases become resectable on response. In this study, IFL plus or minus bevacizumab, there was an increase, but in this study, there was no change, and this is a problem in the interpretation of this data. It may be the case, maybe that VEGF inhibitors result not always in the change of the size of your tumor, but in change of the heterogeneity. And you see here there's complete necrosis, but the size have not changed, meaning that if resection is concerned, it may not have changed the outcome. Now you've heard about the FIRE3 study looking at the comparison of FOLFIRI with cetuximab or bevacizumab. And again, we look to make the metastasis resectable about the response rate, and there was statistically no difference into the two. The only statistical difference was on overall survival in favor of cetuximab in patients with RAS wild type. What should be the duration of preoperative chemotherapy in these patients? Well, one aim important is to convert these patients to resection, and thus a hope for cure. So chemotherapy should be discontinued when metastases have become resectable and not given until best response is observed. Overtreatment can damage the liver and preclude surgery. And this means that these patients should be discussed not only at the beginning of treatment, but every 3-4 cycles during multidisciplinary meetings. Now, resection after patients have received chemotherapy, resection of liver metastasis, I think now, never say never at the beginning. Keep eyes open and be aware that resection does not solve also all the problems, because after resection, up to 80% of the patients have cancer relapse. Is there a need for resection of the intact primary after chemotherapy for synchronous metastasis? Where if there's progression of the metastasis and asymptomatic primary, of course not. If there's a tumor response, yes, resection of the primary, in particular if resection of metastasis is considered. Complete tumor response on primary tumor, this has to be discussed. There's no clear answer. Now we move to metastases which are resectable from the beginning. And of course, the treatment options are chemotherapy, surgery of the primary tumor, surgery of the liver, which order, this has just been discussed. This has also been referred to. It's a retrospective study of 2 institutions in the US, which showed that after resection, survival improves over time. And during the last decades, it has come almost to not very far from 40% at 5 years. And this is also a register. In June 2000, almost 15,000 patients in, and you see here at 5 years, we are almost at 40% with most of these patients surgery only. Now, how can we do better? So the question is, should we give the chemotherapy in this patient with synchronous mets after resection of the liver mets or before? The problem in this field, we have very few studies. This is a pooled analysis of 2 studies with 5FU. Patients receive chemo after resection. You see, this was published by Emmanuel Mitri, and there's a trend toward the benefit of patients receiving chemo after surgery. My opinion is that it's easy to do, easy to administer, but I don't think we have sufficient evidence, because after this study, we have almost nothing. There have been attempts to organize trials, particularly to look chemo before compared to chemo after. Until now, these trials have failed. So I think there's no sufficient evidence to consider chemo after as a standard. Now, you know about the EORTC trial, which compared patients with up to 4 resectable metastases, surgery, and surgery with FOLFOX before and FOLFOX after. I don't go into the details. The primary endpoint of this study was PFS, and the results were published in 2008. There was 8% benefit. Some could consider this is disappointing, not more, but this is the size of the improvement in most studies in GI oncology. Usually, you never get more for each. This is an improvement which is step by step, and this was significant with peri-op chemotherapy. Just to remind you that the aim was to demonstrate that chemo combined with surgery was better than surgery alone. It was not to compare pre versus post-op chemotherapy, which is very difficult to do. There was an attempt in the US to start a study with this, which has failed after there was almost no inclusion in this trial. So we are still left with the question. So the conclusion was that you could get a reduction of the risk of relapse of cancer by relative reduction by 1/4. Now, Dr. Sorby will speak about the predictive factors. And this study has been analyzed for overall survival. This was not the primary endpoint, but we looked at the data for overall survival. This was presented at ASCO last year and published in Lancet Oncology. There was a benefit of 4% with chemotherapy, but this was not statistically significant. It could not be with 360 patients. You can get a significant difference only with 2,000 patients, which will never be obtained in this kind of study with resection and surgery. So we are left with this question. Now, are there indications not to do chemo before? Small and poorly located metastasis which may disappear could be an indication to avoid pre-op chemo, or small synchronous metastasis, which indication to resect the primary because you cannot wait. And of course, if you find it, the surgeon takes it out at the same time. Now, I just want to give a note of caution because it happens that some compare the results of the ERTC study with studies or with the pooled analysis of chemo after. These are not the same patients. You cannot compare the outcome because these are not the same patients. All these patients, those who appear to be ineligible, they are in the analysis of the pre-op in ERTC study. They are out because they have not received resection. Those with no metastasis found, they are in, and here they are not. No resection for any reason. They keep being analyzed in the pre-op study. They are, of course, not in the post-op study. Complication of surgery contraindicating post-op chemo, they are in, and here they are not, and post-operative study. So these are not the same patients, so you cannot compare the two groups. So what about targeted agents in resectable metastasis now? Standard FOLFOX. Should we extrapolate that the most effective regimen is the best? Well, then if you do that, which reference, adjuvant or metastatic, the answers could be different. So the only way is to organize trials. What about targeted agents and the risk of surgical complications? EGFR blockers, there's no known interference with surgery. VEGF inhibitors, we know now that if we delay liver surgery for up to 6 to 8 weeks after that administration, there's no increase. Now, the question which remains, what about the primary intact in a patient receiving bevacizumab? I have no answer to that. What about the ongoing trials? You've heard about the so-called New Epoch trial in the UK, which compared patients, FOLFOX or XELOX, with or without cetuximab. And the investigators concluded that patients with only FOLFOX did better than patients with FOLFOX plus cetuximab. So the question, is this definite answer to this question? And should we move to something else or not? I have some comments on my analysis and the limits of the trial. First, this is an intermediate analysis with some of the data are not mature. Only 233 out of 272 randomized patients are analyzed. This means that 20% are not analyzed. There are questions about quality assurance of surgery. 40% of patients in both arms have a margin of less than 1 centimeter. R1 resection, there are more in the cetuximab arm, which could explain why the outcome is less good. There are 15% patients not accessible, 20% have received capox, and unresected, there are more in the cetuximab arm than no cetuximab, and these patients are analyzed for the final endpoint. So I think we should get this data. They do exist, but clearly they don't set the definitive answer. ERTC has opened the BOSS-2 trial, which is a 3-arm phase 2 randomized in RAS wild-type patients comparing standard FOLFOX before and surgery. Same with panitumumab before and after. or same with bevacizumab. This trial is open and has started accruing patients. Now, in patients who come out to be mutated, then this trial will open very shortly in RAS mutated patients, again, standard arm, and then we have two arms. The VEGF inhibitor here is aflibercept, and since we don't know if the best partner is oxaliplatin or irinotecan, at the beginning we have three arms, and we delete one of these two after 1 year. So if you are interested, you are welcome to participate. What about the duration of chemo in resectable metastasis? 6 cycles. Could fewer be sufficient? Maybe, but I don't think this is the problem. So the rationale for preoperative chemotherapy for synchronous meds, it can reduce the risk of relapse. It allows to operate on smaller metastases, and the rate of primary-related complications is low. You can also administer chemotherapy between the two surgeries. Now, specifically on rectal cancer, because most of the information we have are on a mixture of colon and rectal cancer, in particular in ERATC trial. So there's no randomized trial, only retrospective data, and a minority of patients with rectal cancer. The treatment options, which I have tried to summarize, depend on the site and extent of the primary tumor. If you have a cancer of the upper third or a lower T2, then there's no need for radiation. This is easy. I think we can use the same strategy, whatever you choose, then for colon cancer. Then if there's a mid or low T3 and 1 or T4 and 0 rectal cancer, then the objectives have to have a local control of rectal cancer. Then you need radiation or chemoradiation, and then to avoid progression of metastasis during the treatment of the primary. And this is not easy. So there are several options. First is neoadjuvant chemo plus surgery. The advantage is you have good treatment of liver metastasis. Limitation, you have suboptimal control of rectal cancer. Simultaneous surgery is feasible only for small and easily accessible liver metastasis. And for other patients, then we come back to the question, which resection first, primary or liver? Option 2 is chemotherapy followed by short course radiation. The advantage are good control of metastasis, because we have chemotherapy, better local control of the primary tumor, which is okay for a T3, but may be insufficient for a T4 when you need shrinkage of the rectal tumor, and you don't get that if you operate right after 5 days. Does not delay surgery, rectal surgery first, interval CT, and liver. Third option is chemo radiation. The advantage is better control of rectal cancer. The limitation is that it's suboptimal control of liver metastasis during chemoradiation and delayed surgery. Then this would mean rectal surgery first, interval chemotherapy, and resection of liver metastasis. And finally, before concluding, the option 4 is to start with chemotherapy, then chemoradiation and surgery. When the patient has received radiation, then there's a need to do the resection of the rectum within a certain delay, so this sets the time. The advantage of this is that there's control of rectal primary and metastasis because patients have received good doses of chemotherapy and chemoradiation, then rectal surgery, interval chemotherapy, and resection of liver metastasis. So these are the principal options in dealing with that. So to conclude, there's no universal approach to synchronous liver metastasis, in particular when the primary is a rectal cancer. The treatment strategy, preoperative systemic chemotherapy, surgical approach based on the response to chemotherapy, patient physical status, the extent of primary tumor and liver metastasis, and the operate site at, I think, should operate the site at higher risk of progression first. So if the liver, you have a big liver metastasis and small cancer of the rectum, start with the liver. If it's the opposite, start with the rectum. Thank you very much for your attention.
So, thank you very much, Bernard. I think we will take the question at the end of the session.